Despite all of the research that has been done on COVID-19, two mysteries persist. First, the rates of cases and death vary tremendously across the world by more than 2 orders of magnitude, from anywhere around, say, 3 or 4 cases per million in places like New Zealand, Australia, Japan, and South Korea, to literally hundreds per million in places like Spain, Italy, the United States. No one knows why. The second mystery is that children very rarely get COVID-19, and when they do, they almost never die. This is in contrast to what happens with influenza, where they are very susceptible to high rates of death from bacterial superinfections, and very different from what's going on with adults in COVID-19. I'm Bob Root Bernstein, a professor of physiology at Michigan State University, and my latest paper is called Age and Location in the Severity of COVID-19 Pathology, Do Lactoferrin and Pneumococcal Vaccination Explain Low Infant Mortality and Regional Differences. My basic hypothesis is that the two mysteries I've just discussed are related, that infants don't get COVID-19, and that rates of infection with COVID-19 among adults across the world vary because of one important factor, and that is vaccination. In particular, vaccination against pneumococcal bacteria. So pneumococcal vaccines are used across the world, but at very different rates. Many children get them starting at 2 months, and they are recommended for at-risk adults who are anywhere from 18 to 65, and they are recommended for adults over the age of 65. When I looked at the combined rates of inoculations against pneumococcal bacteria and the vaccination rates across the world, which are shown at the top here, places that have very low rates, which are shown at the bottom of COVID-19, had very high rates of vaccination. So places like Australia, New Zealand, Japan, South Korea, which are in dark blue on the upper part of the image here, have high rates of pneumococcal vaccination, very low rates of COVID-19. Now, I did lots of statistical studies. These are correlation graphs, and the correlation here is very high. It's 0.72 or 0.73 for the sum of pneumococcal vaccinations versus case rates of COVID-19. And that's an extremely suggestive correlation coefficient, very high for this kind of a study. I also ran many controls. There are no significant correlations with other vaccines and their use across the world. I also controlled for population factors, and again, there were no correlations. Therefore, these are not affecting the result. Now, getting back to the children. Vaccinations, as I mentioned before, start at age 2 months. Therefore, children will be protected if they are vaccinated, and this correlates well with the vaccination rates in all of the countries and whether people get, or the infants get COVID-19 in the first place. Infants are also protected by components of breast milk. And these include the antibodies that the mother has. So if she's been vaccinated, then she will protect the infant. In addition, breast milk contains a number of proteins that include casein and lactoferrin. Lactoferrin particularly is important here because it's been found to actually bind to and inactivate COVID-19, both in breast milk, and you can buy it at nutrition stores. It actually has been shown in high doses to protect adults and potentially to treat COVID-19 infected people. Therefore, this is something that needs to be looked into in addition.